Hi, everyone. Thanks for taking your Saturday afternoon, I guess it is for a lot of us. It could be morning if you're out west. And my goal today is just to kind of give a 101 on pancreatic cancer and just kind of talk about some of the things going on in pancreatic cancer and also talk about some of the things that are coming up in regards to pancreatic cancer. These are my disclosures. So don't really need to see this because I had an awesome introduction from Stephanie. But I did go to U of T for my MD and PhD before going to Queen's in Kingston, Ontario, for all my further training. And I started in Halifax in about 2015. So I've been here about 7 years now. So my objectives. So I'm going to talk about pancreatic cancer, talk about some of the newest statistics in Canada, early signs, symptoms, diagnostic assessment, some current treatments, and what the future holds as well. Some words of wisdom. So accessibility to testing and treatment, it differs from province to province and from country to country. And I know that there are people not from Canada as well. I will highlight some things in the US as well, but it's really good to note that I am going to be focusing mostly on Canada because that's what I'm aware of more so. It's also important for you to speak to your cancer care team when you have questions, concerns. They will know more about accessibility to things in your area and can kind of help guide you a little more thoughtfully than I might be able to. And it's also important to let your cancer care team know if you're taking things outside of their treatment. It's always important for us to know everything that someone's on because sometimes you run into issues without realizing what is causing the issues. And if you're not aware of what individuals are taking, it can affect things down the road. Okay, so just a reminder, where's the pancreas? So the pancreas is this yellow organ here, kind of long, elongated thing, sits by the stomach underneath the liver, attaches with the pancreatic duct into the common bile duct, entering into the duodenum. The pancreas is really two organs, and I always like to remind people of this. There's what we call the exocrine portion. So it's the portion that produces your digestive enzymes to allow you to digest food, and it delivers into your duodenum. That's about 80 to 90% of your pancreas. The other remaining percent is what we call the endocrine portion, which is the portion that secretes the hormones to help maintain your blood sugars, the insulin and the glucagon. And so when you look at the schematic picture of it, this is the exocrine, so the one that produces digestive enzymes. They're called acids, and they're made of pyramidal secretorial cells that will secrete things into these ducts that will then enter into your duodenum. Then there's the endocrine portion, which composes of alpha cells and beta cells that produces the insulin and glucagon, which helps control your blood sugars. And gets secreted into your blood system. Under a microscope, this is what it looks like. So these small circular areas are your pancreatic acini, and these areas here that you can see here are the islets of Langerhans, which is composed of your alpha and beta cells, which controls your blood sugars, and these are your blood vessels here. So pancreatic cancer is not just pancreatic cancer. There's the traditional ductal adenocarcinoma, which comprises about 80%, and that's mostly composed of the ducts of the pancreas. But there is about 10%, which are other exocrine tissues, which is like the acinar, the ones that secrete the enzymes, and they account for about 10%. And then there's 10%, which is the neuroendocrine, which are the alpha and beta cells for pancreatic cancer. It's important that we distinguish these because when you look at the data, there is differences in how people do depending on what type of cancer it is. And this is why you always hear the oncologist say, I need a piece of tissue, because we need to know what we're dealing with, not just for how a patient's going to do, but how we're going to treat them as well. So for the bulk of my talk, I am actually going to stick to the traditional adenocarcinoma of pancreatic cancer, the 80-90% of pancreatic cancers as well. This is the one that has affected the lives of a number of people in the media in the last decade or two, such as Patrick Swayze, Alan Rickman, Ruth Bader Ginsburg, Alex Trebek. And it's getting a little more notoriety because it's been affecting more and more individuals as well. So let's jump into statistics. And so these are Canadian statistics because I don't actually have access to the American statistics per se. The lifetime probability of developing cancer in Canada is almost 1 in 2. So 1 in 2 individuals will develop cancer in their lifetime. When you look at the geographical distribution of cancer in Canada, and this is all statistics that came out this year based on the 2021 data, when you look at the highest incidence rate, so new cases in the provinces, so you think dark blue is the highest, and as it gets lighter, it becomes less and less. You can see that Atlantic Canada has some of the highest incidence of cancer, and Ontario as well, whereas you think more of central Canada, it's less, and then BC, Yukon, even lower. And that's the left side. On the right side here, this is the mortality. So the incidence of number of patients who pass away from cancer. And as you can see, again, dark blue highest, and as you get lighter, it gets lower. You can see Atlantic Canada, Nova Scotia, and Newfoundland has some of the highest rates, as well as Nunavik, of death rates from cancer. And so when you look, at least for Atlantic Canada, when you have high incidence, high mortality, that's not a good equation to see. So when we now talk about pancreatic cancer, it's the 10th most common cancer in men, 9th most common in women, and that's similar in the US as well. In Canada, we expect about 6,700 cases of pancreatic cancer, a little bit more men than women. I'm not going to belabor this, but you can see the distribution in the different provinces. So it's not that rare per se, but depending on the size of your province, your family physician, for example, may only see 1 or 2 cases every couple years of pancreatic cancer. So when you look at the survival data for cancer, while you see very good survival data when you talk about colorectal cancer, breast cancer, prostate cancer, the yellowish brown line, this is pancreatic cancer in Canada. You can see that the survival curves aren't as good or anywhere near as good as you see for the other disease sites. And this is mimicked in the US and elsewhere in the world as well. So the survival rates aren't great, which is sobering and sad, to say the least. By 2030, we're going to see pancreas being the second leading cause of cancer-related death. This is American data, but it's similar in the US as well. Lung being number 1 and liver cancer being number 3. Right now, pancreas is tied for number 3 for leading cause of cancer-related death. In the plus side for Canada, we're seeing this trend of over time of increased survival. It means that patients are doing better, but again, this is heartening to see that we're seeing a general increase over time, but again, it's not substantial increases over time. And again, if you just compare between 2012, 2014 to 2015, 2017, you're again seeing increases. From my perspective, from Nova Scotia, which is where I'm at, we were always quite perplexed with the extremely low survival rate. But the newer data is now showing that we're competing with the rest of Canada with regards to survival, which is excellent. So then we start thinking about why is survival poor for pancreatic cancer? Is it genetic differences with the disease? Is it the referral rates? So pathways of patients getting diagnosed, getting imaging scans, getting biopsies, getting to see a surgeon, getting to see an oncologist, getting on treatment. Are there blockages or delays in this linear pathway for getting things done? Is there some kind of cost that's associated that is limiting how patients are being seen, treated? Is there difference in treatments, or is there this nihilism that's out there that you have pancreatic cancer, nothing to do, which is something really old from decades ago, which has changed definitely over the years. So, keys to improving outcomes. Really, when you start thinking about it, you think about how do we prevent it? How can we early detect it? And can we come up with individualized treatment plans? Oops. Oh, there you go. Okay. So when we look at risk factors for developing pancreatic cancer, which is kind of what we're thinking about, how do we prevent it? Most of pancreatic cancer, we really don't know what the risk factors are involved. A lot of the things we talk about are kind of generalized risk factors for cancer in general, and we attribute it to pancreatic cancer as well. So things like smoking, alcohol, diet, some of those have been potentially linked partially to pancreatic cancer. So when we think about prevention, we always tell patients, healthy diet, limiting alcohol intake, smoking cessation, exercise to try to prevent not just pancreatic cancer, but all cancers. But of course, this also leads to a healthier lifestyle, which reduces the chance of other things like diabetes, heart disease as well. But specifically, these affecting pancreatic cancer, the data is very limited at this point. You may ask, what's your family's risk of developing pancreatic cancer now that you may have a family loved one with the disease? When we look at the cancer in general, based on the statistics, so about 5 to 10% is what we call hereditary cancer. So there's some kind of gene in the family that gets passed on from parent to child, which leads to an increased risk of developing a pancreatic cancer. Then there's a 5 to 10%, which is what we call familial cancer. So there is a shared factors, environment, lifestyle, which puts you at a slightly higher risk of developing pancreatic cancer. But the reality is with pancreatic cancer, 89% of it is sporadic, which means that there's no clear gene or environmental lifestyle, which leads to this risk, or we don't know that there's a gene in that group or lifestyle or environmental factor, which is leading to this risk of pancreatic cancer. So, but really, we're quoting about less than 10% chance of it being hereditary. When we now start talking about screening, so unlike other cancers, there's really no reliable screening method for pancreatic cancer. There is this tumor marker called CA19-9 that is used, but it's not a reliable screening tool. Anything that affects the biliary tract can cause the number to go up, including infections, including gallstones, inflammation, all that can cause that tumor marker to go up. So it's not very specific, and you can get a lot of false positives and false negatives with it. We do use it, though, to track how the progress of patients are with diagnosed pancreatic cancer on treatment. But again, it's not a great tool to use for pancreatic cancer. And unfortunately, there has been no other tools. There's been a lot of research trying to identify other screening mechanisms for pancreatic cancer, but nothing has really panned out. So when we think about early detection, because we don't really have great prevention or screening, because there's no real good tools for early detection, really it comes to the patient and the primary care provider being very key players in the early detection. And usually it's recognizing the symptoms that might lead to further investigation for the disease. And some of the early signs for pancreatic cancer, some of this include jaundice, pale smelly stools, new onset diabetes in people that don't have associated weight gain, upper abdominal pain, and unintentional weight loss. But you can see some of these are very non-specific and could be multiple other things that can cause it. And so it's up to the physician, primary care physicians primarily, to have it on their radar that it is potentially something that should be looking at for investigating. And we're doing a lot of education, primary care providers, to try to for them to recognize that if their patients are presenting with some of these signs and symptoms, they should potentially be looking at further investigation. Why is early detection important? Well, we know that earlier you detect it, the better the outcomes are. The earlier you detect it, the earlier the stage, the better candidacy you are for surgery, as well as chances of you being well enough to go on treatment like chemotherapy or clinical trials. So, how do you diagnose pancreatic cancer? Well, the diagnosis assessment usually involves blood work, some kind of imaging scans, whether it's ultrasound or CT scans, getting those tumor markers, and then at the end of the day, a biopsy. Now, ultrasounds, I always like to highlight, are very limited in their usefulness. They're good at ruling out benign causes, so things that aren't really cancer, like gallstones, for example. It's inexpensive, there's usually short waiting lists to get it done. But the pancreas itself is very poorly seen on ultrasounds generally. So a negative ultrasound is not necessarily reassuring that your pancreas is normal. And so if you still have a high suspicion, you really need to have a CT of your abdomen and pelvis. If you're concerned about the pancreas, CT is the best. It's what the American College of Radiology supports from their guidelines. Early CT to evaluate pancreatic cancer is really important because it gets to a better earlier diagnosis of the disease. You will hear oncologists say, we need a biopsy, we need tissue. And I always say tissue is the issue. The reason why we say this is because while 90% of spots in the pancreas is pancreatic cancer, 10% of it is not pancreatic cancer. Could be lymphomas, could be neuroendocrine tumors, could be disease from other diseases, breast cancer, kidney cancer, melanoma. They also go to the pancreas as well. All these diseases are treated completely differently. And so without knowing what you're treating, because you don't have a tissue, you may be putting someone on futile treatment, and you get side effects from these treatments as well. And so you really want to be treating what the diagnosed entity is. And so we always want a piece of tissue. After a diagnosis, so say the patient has been diagnosed with a CT scan, we'll then say, get more imaging, get a biopsy. If they've had a biopsy, then they should be referred to a hepatobiliary surgeon to discuss surgical intervention. Should be referred to a medical oncologist who will then discuss do they need treatment or not, and should be presented at tumor boards if it exists at the center as well to discuss what should be the proper treatment algorithm for that patient. You'll hear the words, what is the staging of the tumor? And staging, so TNM is the tumor nodal metastases staging by the American Joint Committee on Cancer, AJCC. Stage is based on the size of the tumor. Does it involve some of the veins or arteries? Are lymph nodes involved, or has it spread to other organs? A lot of oncologists actually don't use the TNM staging when we talk about pancreatic cancer, because we use something what we call real world staging. And we talk about, is it resectable? Is it borderline resectable, as in is partially wrapping around some of the blood vessels, but might be removable if they get some treatment? Are they locally advanced, as in they've wrapped around the blood vessel, but they're not, they hasn't spread elsewhere? Or are they metastatic? Have they spread to other organs? And that a lot of times will dictate how we're going to treat it, and that's how we discuss things at the tumor boards. So the current pancreatic cancer treatments, you can have surgical intervention, which is pancreatectomy or Whipples, chemotherapy plus radiation, stenting, clinical trials, and best supportive care. I'm going to go through each one very briefly. So when we talk about intervention, you can have a Whipple procedure, which is typically occur if you have a pancreatic tumor at the head of the pancreas. And a lot of times they remove the part of the pancreas, the duodenum, part of the bile ducts, they reconstruct it as well, and part of the stomach gets removed. They're big surgeries with long recovery times. If it's at the tail or body of the pancreas, a lot of times you may have a distal pancreatectomy or a total pancreatectomy, which again, they're all large resections. There's long recovery times as well. So they're not simple surgeries. And you also usually need a very highly trained surgeon to do these kind of surgery. So a general surgeon typically aren't the ones who will do these. It's usually more hepatobiliary trained surgeons that will do this. When we talk about treatment, chemotherapy, for example, I like to keep things simple. So you can give treatment before surgery, which is called neoadjuvant, to try to shrink the tumor to get it to surgery. Then there's adjuvant, which is treatment that we give after surgery to reduce the chance of this cancer coming back. And then in the palliative setting with the stage 4 disease, the goals of treatment is improve the quality of life and possibly improve survival as well. there are a number of treatments available. You'll see that the treatments seem to be similar between palliative, adjuvant, and neoadjuvant. For pre-surgery, the only data right now is single-agent gemcitabine, which is a type of chemotherapy drug. There are trials going on looking at other treatments like FOLFIRINOX and gemcitabine plus Abraxane, as well as chemo plus radiation, but they're ongoing right now. Adjuvant treatment, we have clear data about these two regimens. And in the palliative setting, we have clear data about these regimens. You'll see for people who have progressed on gemcitabine plus Abraxane, there was a study looking at Onivide, which is liposomal irinotecan plus 5-FU. In Canada, unfortunately, while it was Health Canada approved, it's not funded in the country. So the only way to access this is if you have private insurance, and not even all the private insurance plans do cover it as well. In the US, it's a much more accessible treatment, and in Europe, it's much more accessible treatment. When we talk about neoadjuvant treatment for pancreatic cancer, the general schema fluctuates from center to center, province to province, but it's generally about the same. There's a treatment phase, which could involve 3 to 8 months worth of treatment. There may be restaging scans in between treatments to determine the potential of taking someone to the OR. There may involve chemo plus radiation, and then restaging again, and then going to the OR. But you can see it's a very lengthy time. We're talking about 3 to 10 months worth of time, potentially, before someone may make it to the operating room for removal. When people sometimes ask, what's the point of chemotherapy? Does it really work? And we know from studies that when we give chemotherapy after surgery, historically, the median survival, so this is the time it takes potentially for the cancer to come back and to get people at the end of it all. If we did nothing, which was what we used to do back in the 1990s, pancreatic cancer, we know, has a high risk of it coming back. And we know that with chemotherapy, things have improved greatly to the point that we've almost quadrupled the chances of living a long time after surgery. And so most people I see after surgery, I offer chemotherapy because the data is just so strong to recommend chemotherapy versus not doing anything. So what are some of the side effects you should expect from chemotherapy? And it's a laundry list that you can see. So you can look at things like you could develop some nausea or vomiting, diarrhea, feel more tired, hair loss, sores in your mouth, muscle aches and joint pain, numbness and tingling in your hands and feet, weight change, memory impairment, your immune system can be suppressed, loss of your libido, infertility issues, bruising could increase, mood swings up or down, skin sensitivity. There's a risk of blood clots. So having pancreatic cancer increases your risk of blood clots. Being on chemotherapy can put you at risk of developing blood clots. Risk of infections, nail changes, dryness to your hands and feet, belly pains, and dehydration. How many of those someone may get, it's hard to say. Everyone's different. Everyone responds to treatment differently. Some people do well. Some people have a lot of side effects. It's unless you try it, you don't know how it's going to be. But as an oncologist, my duty is to mention that these are all potential things that someone could experience while they're on chemotherapy. It's important to understand that drugs all have side effects. This is just a list of potential side effects that one drug could have, that drug being aspirin. So lots of people are on aspirin. How many people get these kind of side effects? Not that many, but these are all listed side effects. And it's important to understand that side effects are listed because they were reported on a clinical trial, that one patient may have experienced this while they're on the clinical trial. It may have been secondary to the treatment, may be secondary to the cancer, may be secondary to something else. But because it happened on the clinical trial, it has to be reported and listed on it. So I always highlight the patients that while there's a laundry list of side effects that the treatment could cause, they may not experience that. Because again, aspirin, a lot of people don't get side effects from a baby aspirin. So chemoradiation. So we talk about chemoradiation. There's contradictory studies to suggest its role. Some centers do use it before surgery or even after surgery, and sometimes if patients are having issues from the tumor, they may radiate to help alleviate, say, for pain, for example. It's really based on tumor pathology. It may dictate what to do, and these cases need to be reviewed in multidisciplinary rounds to kind of decide what the best course of treatment is for the patient. And there's newer modalities on how to give radiation, number of treatments, how long the treatments are. And so it's always important to see a radiation oncologist as well to talk about this. But really, it's getting these patients seen and presented at tumor boards to kind of discuss what is the proper pathway for the treatment of this patient. Additionally, at least for patients who have exhausted all treatment, referral to palliative care for help with supportive care with the oncologist is also very important as well. And it's something that we recommend down the road for patients as well, because they can definitely help with symptom management. So how do you support someone on chemotherapy? And this is what I usually, my team tells patients and their support caregivers. Make sure that the patients are drinking water. The people that are on treatment sometimes don't really have an appetite or don't have a thirst. And drinking water is important for elimination of the treatment from their body. Assist with meal prep. You know, sometimes people just don't have the energy to want to cook, and making meals can be daunting for some people. So helping with meal prep is very important. Have them stay busy and active, but get them rest when they need it. Be there to support them while they're on treatment. Emotional, physical support, it's very important. Be another set of ears for the patient. There's very clear data that when people see their oncologist the very first time, they only hear about 10% of what is said, because it's a lot of information and there's just so much that can overwhelm people. Having a second set of ears is important because they hear more. Now, with COVID these days, we're not allowed to have multiple sets of ears in the room, but you can be an ear on a phone, for example, and can call in and listen to the conversation as well. And I usually advise that for people. Be their voice when they can't be, but listen to them as well. I think that's also very important. The best advocate for patients are the patients and their family caregivers. But also listen to the patient too. If they're telling you something, it's important to hear them out. And make sure they take their supportive meds. When their appetite is low, when they're not drinking, a lot of times they're not taking their supportive meds as well. And so you want to make sure that they're actually taking those medications while they're on treatment to help improve their symptoms. Clinical trials. So it's always important to think about clinical trials as a potential avenue for treatment. The clinical trials help determine the treatments of the future. Patients may be eligible for clinical trials even if they have exhausted standard care options, and they really need to speak to their oncologist regarding clinical trials. Great source for active clinical trials in, I say province, but actually in North America is clinicaltrials.gov. In the past, patients were told to get their affairs in order way back in the day, but now there's other treatment options out there. So it's important that they speak to their oncologist, see what's out there that can open up, and they exhaust everything that's out there. To give you an idea, this is clinicaltrials.gov, and it's a search engine. All clinical trials in North America need to be listed on clinicaltrials.gov. So if you type in all studies, pancreatic cancer in Canada, and again, you can do this for the US and other countries as well, and hit search, there we go. You'll find right now there's 41 studies in Canada that are recruiting or not yet recruiting, but are active as well. And you can then see what is the condition, pancreatic cancer, what are the interventions, as well as what are the locations that are involved. And if you click on it, it'll then expand it and tell you more about the locations, what the treatments, and you can bring this to your oncologist and say, hey, is this a potential option? Now, a lot of times you can see which centers are active with the study. It means that if your center is not open or listed on there, it means they're not running that study. So if you need to access that study, it does mean going to the center listed there to access that study. So one of the things that people ask is, well, can we get that study open in our center? One of the issues with clinical trials is it takes about 8 months to open a study on average. So it's not an easy thing. And secondly, especially with industry studies, they have very limited allocations to which locations they can open studies. So unless you were selected to open the study, it's really difficult to open a study that is not already active to begin with in your center, which is why you hear things as you'll need to go there to access the study. What about immunotherapy? So we talk about immunotherapy for cancer, and I always get this question about what about immunotherapy for pancreatic cancer? So just to get everyone on the same page, immunotherapy, so currently, the way the cancer evades the immune system is it expresses this blocker, which blocks your immune system, your T cells, from recognizing it's a cancer cell, and it doesn't allow your immune system to get turned on. There is something called immunotherapy, which can block the blocker, which then allows your T cell or immune system to recognize that it's a cancer cell and then attack it. So that's the way immunotherapy works. It blocks the blockers to allow your immune system to actively attack cancer. And we use immunotherapy in things like kidney cancers, lung cancers, melanoma. But what about pancreatic cancer? So unfortunately, when we look at immunotherapy studies, when we talk about single agent or doublet immunotherapies, they've all been ineffective. So these are the various different immunotherapies. Response rate means that their cancer responded to treatment, i.e., they may have stabilized or shrunk a little bit. And you can see the response rate is abysmal, 0%. So this is not even talking about did it change the outcome at the end of it all. It's just did the cancer respond. And then most trials now are looking at chemotherapy with immunotherapy and looking at response rates. But again, the response rates are similar to just chemotherapy alone. And so they're not more effective. So immunotherapy has not been shown to work for pancreatic cancer. And there's been many studies which have shown this, which is why a lot of your oncologists usually aren't even talking about immunotherapy. However, is there a subset of pancreatic cancer patients that might respond to immunotherapy? And there might be. So there is this pathway in our body called mismatch repair. And there's 4 molecules that are part of this pathway. And what they do is they identify mutations in your DNA. So our DNA is composed of 4 things, A, C, G, T, and they kind of match together. And sometimes those matching don't work. G is supposed to match with C's, A is supposed to match with T's. But sometimes an A may get matched with a G, for example. So that's a mismatch issue. These molecules can then identify that mismatch, cut it out, and then allow your DNA to come back together. When you have mutations in these pathways, it allows the body to develop more and more of these mismatch mutations. And we know now that immunotherapy, patients with these mismatch mutations, they respond to immunotherapy better. And so now if you look at the NCCN, which is the National Comprehensive Cancer Network, it's in the guidelines now that immunotherapy for MMR deficient cancers should be considered as a treatment option for pancreatic cancer, as well as other cancers as well. So there is a subset of pancreatic cancer which does seem to respond to immunotherapy. And you'll sometimes will hear your oncologist say, I'm going to send your tumor off for some testing. A lot of times it's for this kind of testing to see if you might be a candidate for immunotherapy. Now, in Canada, unfortunately, there's a lot of hurdles to getting immunotherapy if you have these kind of mutations, but it is doable in many centers. Let's talk about the wave of the future and where things are going. So I always like to say we practice something called imprecise medicine. We see a patient, we give them a drug based on their history or their presentation. We know based on the data that approximately 50% of patients do not respond to the prescription drugs. And there's a study out of Nature where they showed that they looked at the top 10 prescribed drugs in the US. If you look at, say, Nexium, which we use for heartburn, you have to prescribe to 25 people to have one person to respond. Crestor, which we use for cholesterol, you have to prescribe to 20 people in order for one person to respond. So a whole bunch of people don't respond to the medications that they're on. And so without precision medicine, we give the same drug to all these different people. Some will benefit, some won't benefit, some will have adverse effects. With precision medicine, it's taking something, a lot of times DNA, for example, and tailoring their treatment based on the precision medicine. So you're giving different treatments to each individual. Another way to think of it is like, think about your lawn. You spend all this time cultivating your lawn. It looks great, but there's this weed, this one weed, pesky weed, won't go away. So then you give this generalized weed killer and it just nukes your whole lawn. It's completely barren. You can think of this like cancer in chemotherapy. This weed is your cancer cell. Chemotherapy is the weed killer. And then what it does, chemotherapy, is it not just only attacks your good cells or your bad cells, which is the cancer, but it also attacks your good cells, which is why you get all the side effects. So it attacks your body. Now, what happens if you're able to figure out what kind of weed that is and tailor the treatment to that particular weed? Well, then you'll end up leaving the rest of your body okay, but you're still able to kill off that weed. And that's the idea of what precision medicine is. Another way to look at it is I take chemotherapy, which is like a nuclear bomb to your body, whereas precision medicine is taking a scalpel to the tumor. So precision medicine is taking the piece of the tumor from the biopsy or for the use for diagnosis, and then creating what we call a personalized tumor profile, which is through sequencing, which then identifies targets or druggable pathways that then the doctor can then prescribe some kind of drug based on those targets. Can use for diagnosis, prognosis, clinical trials availability, cancer susceptibility, and therapy selection. So it's not just for therapy. It's entered the guidelines in the NCCN, so the National Comprehensive Cancer Network guidelines, which you can see here. It is 2019 guidelines, so this is a couple years old now. Precision medicine's not something new. It's been around for a while. When we look at breast cancer, we've been doing this for a long time. So this is the 1970s, where we knew that breast cancer can express estrogen receptors, which takes in the estrogen in the body and can turn on cell proliferation. If you were to give them something called tamoxifen, which was an estrogen blocker, you can turn down the cell proliferation in breast cancer. And there's a number of different genes that we're aware of since the early 70s that there are targeted drugs for as well, whether you talk about HER2 for breast cancer, where you talk about KRAS for colorectal cancer, BRAF for melanoma. The idea of targeting treatments for cancer has been around for a while, but it's becoming much more prevalent as time goes on. So the paradigm for how you're supposed to treat has changed. So the idea of standard approach has been to treat cancers based on the organ of their origin. So gastric cancers from different people are treated differently than breast cancers, for example. But the emerging paradigm is that you have to consider the genomic factors. So gastric cancer and a breast cancer that have the same molecular alterations, you should be able to treat them similarly. So does this work for pancreatic cancer? So PanCan has had this Know Your Tumor program for about, I'd like to say 5 years. And this is doing precision medicine on the tumor and looking to see what the outcomes were. And so when they reviewed their data from 2018, they were able to find about a quarter of their patients had mutations that there were drugs out there for that patients were able to get on. And what was published, it's now 2 years, they were able to find that if a patient was able to get on a treatment that they had a mutation for, they actually did better than those who just got standard care chemotherapy or standard care chemotherapy, even though they had a mutation. They actually did better. And this has become more of what is being done in the US right now. In Canada, it's only available through research mechanisms. So there are research programs in Canada, Octane in Ontario, POG, which is the BC Cancer Personalized Oncogenomics in BC. Alberta has their own pancreatic cancer NGS panel. McGill has MAGIC. You can pay for it out of pocket through Foundation Medicine, which is owned by a pharmaceutical company called Roche. It's not cheap. I think it's about $7,500. Or Canadians can access it through the Pancreatic Cancer Action Network as well. So Canadians can actually enroll into the Know Your Tumor program as well. So in Canada, where are some of the hurdles when we talk about this? Well, the cost, who's going to pay for it? Not just the sequencing or the drugs, and then can you access the drugs as well? So having a mutation, and there's a drug out there, usually the way it works in Canada is there's been a trial that shows drug works on tumor, gets approved through Health Canada, and then goes through a whole system before it gets funded. When there's these one-off mutations on a tumor, they have likely not had a study to prove it works or doesn't work. So therefore, a lot of times there's not a Health Canada indication. Sometimes there's not an FDA indication. And without those indications, it can't be funded by the government. So then in Canada, the only way to access these kind of drugs is if, one, you have an amazing private insurance that pays for it. Two, if the pharmaceutical company provides compassionate access for the drug, which I find in my experience is about 5 to 10%, you are able to get access to the drug. Three, if there's a clinical trial out there that has your cancer with the mutation and that drug available. Or four, if the patient pays for it out of pocket. So there is caveats to doing this at the moment in Canada. In the US, there is a new program called Precision Promise, which looks at metastatic pancreatic cancer, either first or second line. They use sequencing, and because they have a whole bunch of pharmaceutical companies involved, they can get potential access to treatments based on their mutations that are out there. So just briefly, just a couple more slides, and then I'm going to keep quiet and let you guys ask questions. So how do you begin to fix the system? A lot of it deals with education, research, economic analysis, and guidelines. The genetic differences you're not going to be able to fix, but it's important to identify it as there are treatment variations based on your genetics. Again, there's a lot of hurdles to things, and unfortunately, a lot of the hurdles tend to be because of time and money. In Canada, at least, and I think also in the U.S. as well. Finding the resources for chair time, nurses, dietitians, social work, clinic spaces is important. Finding the physician, nurses to see the patients, and the money for the new treatments as well. And then, of course, COVID is affecting a lot of this, unfortunately, at the moment. So to summarize, early recognition and detection is key in the improvement of survival of pancreatic cancer. To date, we're still unclear as to why certain areas have different outcomes compared to others, but potentially it's delaying treatments, lack of referrals to appropriate specialties might account for part of it. But there are treatments out there for pancreatic cancer. There's new things coming out. There's new trials coming out. And so it's always important to speak to your oncologist about what is the newest thing that's out there. Lastly, thank you.